Hello again, everyone. I'm Dennis McCarthy with Olean General Hospital and Upper Allegheny Health System, welcoming you once again to Inside Olean General Hospital, our news and information program about Olean General Hospital, our services, our educational programs, and programs that affect your life every day. With us today is Dr. Eric Tenbrock, who is the Medical Director of the Sleep Disorders Center at Olean General Hospital. Welcome, and thank you for being with us.
Oh, good morning, and thanks for having me.
This is a brand new facility that has been open since June, a gorgeous facility located at 500 Main Street across from the hospital in the Mildred Middleman Outpatient Surgery Center. We've been open, as I said, for about a few months now, and we thought it was important to focus today on sleep disorders. It's a time we spend a good portion of our life sleeping, and getting a good night's rest, among other things, is very, very important. But there's an awful lot of problems associated with sleep and sleep apnea, and we'd like to have a conversation today with Dr. Tenbrock to talk about some of these issues. Good morning.
Good morning.
And thank you for coming today. First of all, where are we? We're in the sleep center, but we are where?
This is we have a 4-bed sleep lab open 7 nights a week. And patients have their own beautiful rooms. What this room we're in is the technician's room. They monitor what's going on with the patient, so their breathing, their heart rate, their heart rhythm, their EEG, all on these screens here. And they also have the ability to visualize what's going on in their room as well. So we usually have 1 or 2 techs here monitoring the 4 patients.
So this is basically the nerve center.
This is the nerve center, yes.
Okay, everything happens here, and then on these screens the staff can watches the patient, monitors all kinds of different...
Second by second.
Second by second. Well, we wanted to talk today because, I think there's maybe a misperception in the community that, what is sleep apnea? And most people say, well, it's a snoring problem, but there's an awful lot more that goes into this, and it's a bigger problem than just snoring.
There is. It's true that the vast majority of people who have sleep apnea often snore loudly, so it's a very good symptom to hone in on, as is daytime somnolence, gasping at night, witnessed apnea. But these are things that some people don't have a bed partner, don't know if they do, and it's one way of looking at if someone's at high risk for having sleep apnea. But as you were alluding to, it's really not the only way to make that determination. One of the changes in a perspective that's undergone in identifying people who have sleep apnea is looking to see what comorbidities they have. And comorbidities are other medical problems such as heart disease, atrial fibrillation, hypertension, diabetes. And it's these other medical comorbidities, medical problems, that in many ways put patients at high or low risk for having sleep apnea. For instance, people who have diabetes, 50% of them have sleep apnea. So when you see a patient of yours who have diabetes, in addition to saying, well, let's see what the blood sugar control is, how do you feel, and things like that, you might say, 50% likelihood that they have sleep apnea. How are you doing during the daytime? Are you tired at all? And they go, yeah, a little bit tired. Well, the bar to pursue the possibility of sleep apnea is lowered now because the predisposing likelihood of them having it. So looking at all these other medical problems they have can identify people with that are likely to have sleep apnea.
Well, that's interesting. So what you're saying is, in essence, is that sleep apnea is related to, you said, diabetes, heart disease, people have strokes, and so is sleep apnea a cause factor for those problems?
That's interesting. In many ways, it's bidirectional. Like take heart disease. There's some heart disease, such as cardiomyopathy. The heart's not pumping that well. That can cause sleep apnea, a certain type of sleep apnea, called Cheyne-Stokes respirations. On the other hand, people who have sleep apnea can develop heart disease. For instance, they're much more likely to develop irregular heartbeats such as atrial fibrillation, which is very common, and even they're more likely to develop hypertension. Some studies have looked at individuals who weighed the same amount, had the same cholesterol, habits, and things like that. One group had a normal blood pressure. The other group had, they all had normal blood pressure. And they followed the group that had sleep apnea and compared to the group that didn't have sleep apnea. And 4 years later, the group that had sleep apnea but was not treated had a 3-fold increase of having hypertension compared to the non-sleep apnea group. So here's another situation in addition to arrhythmias where this sleep apnea can cause the problem.
So in relation to perhaps a heart problem, if you have sleep apnea, being a layperson, I'm guessing, you have episodes of your breathing stops, essentially.
That's what apnea is, correct.
And that puts a strain on the heart?
Right,
so
it does. It's a complex sequence of events, but in essence what happens is when you have apnea and the back of the throat collapses down, so now you're choking, the oxygen level goes down, the heart is under stress, the heart rate initially goes down, and then your body, even though you're asleep, you realize, you know, I'd rather stay alive than sleep a few more seconds than not breathe. Right. So there's a quick arousal response. It sometimes wakens the patient up, but most of the time it doesn't. They just make a gasping noise, and now the oxygen increases because their airways open again. The heart rate increases, and the brain waves when you're asleep get fragmented. And catecholamines, a technical term that gets released into the bloodstream. And all of this, the heart rate changes, the oxygen going up and down, the heart in distress, predisposed to having vascular disease of any kind, from hypertension to heart disease to strokes.
Now, you do a lot of work with other physicians and cardiologists and other specialists with regard to patients. So this is really a real continuum, a real comprehensive look at the patient, not just because they snore, not because they have sleep apnea, but you work a lot with other physicians here in Olean to help solve the total problem.
Correct. Many things in medicine is multidisciplinary. Sleep is certainly in the lead in that regard. There are a lot of individuals, from primary care doctors, cardiologists, ENT doctors, psychiatrists, diabetic educators, that all have a role in diagnosing their patients who have sleep apnea and contributing to the treatment that we sometimes offer.
Now, you also said, we were talking earlier, it's not always obese people and people that people obviously overweight folks who have sleep apnea.
Right.
It runs the gamut.
That's correct. Most people are overweight, but not everybody. So it's important not to just see somebody come in your office, and if they're not overweight, just not even consider sleep apnea. You have to listen to what the patient's saying about their sleep, and importantly, first you have to ask questions about their sleep, which often isn't done. Do you snore? How many times do you wake up? Do you gasp? How do you feel when you wake up? You know, if they're tired after an 8-hour sleep, you say, I wonder why that is. And it doesn't matter if the person isn't overweight. They have a problem, and it should be explored. Many individuals who are not overweight have anatomic predispositions. The back of their throat might be narrow to begin with, or their jaw might be set back. And these could be reasons why they, in particular, might have sleep apnea.
So we need to solve the problem. All right, I've got sleep apnea. I come to our center, and so what happens? I know we have machines back there. You evaluate people when they come in, and then they have a sleep apnea machine. Now, what does that machine essentially do, and how does that help restore better health?
Well, what we do here, just to back up a little bit, we have a comprehensive approach to individuals who have sleep problems. We don't do anything piecemeal. Olean General Hospital is an American Academy of Sleep Medicine accredited sleep center.
What does that mean?
Well, that means that we have boarded sleep technicians, boarded sleep physicians, that we have policies and procedures that have been personally vetted by the American Academy of Sleep Medicine, and that there's been a site visit where they come here and they look to see what we do. They go over patients' charts, and then they see if you met the standard of care that they expect.
They put a very tight eye on the kind of things.
Oh, they certainly do. And they leave. They may say, well, you're pretty good, but these are the things that you have to change to be accredited. And when this lab was accredited, it was accredited, we call, without provisos. They came, they said, no adjustment or changes.
Which means you're performing well and
right.
to high standard.
We all breathed a sigh of relief that afternoon.
Well, that's also a congratulations to you and the staff here for really making this a high quality program.
Mm-hmm.
So we were talking about the progression of the study, what happens.
Yes. So a doctor or a nurse might identify somebody who has sleep apnea. They send us a request. We get their medical information, send them a sleep questionnaire. We find out what medications they're on, because that can affect sleep and sleep quality. What time they wake up, what time they go to sleep. We track that for a week. They come in and they have a sleep study. Then the registered technician scores the sleep study, and they visualize every single epoch, a 15-second clip of their sleep for the 5 or 6 hours they were asleep. They score abnormalities as they see it, and then a board-certified sleep specialist looks over that same record. Doesn't just take their printout, but looks over the record from scratch again, makes whatever the changes they feel is necessary, and dictates a report that goes to the physician. If the patient or physician desires, there's a very active office clinical practice here where we see patients who have sleep apnea or other sleep disturbances. We make recommendations for therapy that often includes, as you had mentioned, that CPAP, continuous positive airway pressure device. And when they come to clinic here, they see the doctor and they see the CPAP specialist, just in case there's an issue with their mask.
What does that CPAP machine actually do?
Well, it stands for continuous positive airway pressure, and it's nothing more than an air compressor. It's put over the nose or over the nose and mouth, and it can be titrated between pressures of 4 to 20 centimeters of water. So the higher the number, the more oomph is in the back of the throat. And now there's a column of positive pressure in the back of the throat. It serves as a air splint. It stents open the back of the throat so it can't collapse down.
So the breathing is continuous, normal,
yes.
Doesn't put the strain down,
right.
You don't stop breathing.
It doesn't breathe for you, but it prevents the obstruction. So what I'd mentioned earlier, the oxygen level going up and down, the heart under stress, and the fragmentation of the sleep, that doesn't happen anymore.
Okay. Now, let's talk about how, there's a lot of controversy, if you watch television, national reports, there's a lot of talk about how much sleep does somebody actually need. And I think there's a lot of confusion out there. Is it 8 hours, 7 hours, 6 hours, 9 hours? And it's important, in the whole point here is, I think, because we spend so much of our time sleeping, to get good rest is really an essential part of life, isn't it?
Right. We spend a lot of our time sleeping. We probably should spend a little bit more, because a significant minority of people are sleep deprived chronically, and sleep deprivation interferes with executive decision making. Go through a red light, not go through a red light. What should I do here in quick situations? It slows up the reaction time and makes the decision making diminished capability.
That's interesting. So when people, a lot of folks just figure, at some certain time I'm just going to jump into bed no matter what's going on in my life, and I'm going to go to sleep. There's some information that says you should get into some sort of a habit to prepare yourself for sleep.
Yes, if you should wind down. A nice way to look at it is, you don't go running around drinking coffee, watching TV, getting yourself all worked up, and expect to go into bed, shut the light off, and be asleep 5 minutes later.
Right.
So a wind down pattern is helpful, and that might include anything from avoiding bright lights, because lights are stimulating, to maybe not exercising right before you go to bed, to
read a book.
Read a book, that's nice. If you have anything that some people have intrusive thoughts when they go to sleep. They go, oh, I should have done this today, I got to do this tomorrow, all these things. Don't do that. Don't make bedtime a workstation. So if you're going to think these thoughts, do it in the kitchen, so you sort of figuratively separate it from the bedroom, like the lock box.
Yeah. That's I think that's probably a symptom of a lot of people in societies, particularly in the workforce, that they never shut off work stress, life, home stress, or anything else.
Right.
So that part. One of the things that I wanted to just maybe, as we begin to wrap up the program, this clinic, this sleep center is a very intensive place with thorough examinations. There's some talk about home studies. I guess one of the things that I think and wonder is, well, does this sleep center offer certainly advantages to home sleep studies? And maybe we can talk a little bit about what that means.
It does. There are insurance companies that are interested in cutting costs, so they'd like to have an abbreviated sleep study in the home. And whereas if everything works out well, that can be okay. The amount of data that are obtained is a lot more limited. There's just like 3 or 4 channels as opposed to 15
Right.
channels that we have here. And one of the benefits of having in-lab is that if any of these leads come off or they're misplaced or they move a half an inch or so, there's significant degradation of the product. When you're at home, you're asleep. No one's watching where these wires are. You might
Right.
have inadvertently pressed the button off rather than on, and it gets interpreted by somebody usually or often in a different state. So the American Academy of Sleep Medicine says that if a home study is to be done, it should be done in the context of a comprehensive sleep medicine evaluation by board-certified sleep physicians in an ASM accredited sleep laboratory. So the quality assurance is very tight.
So I think that maybe the word there is, if you want to have a thorough, in-depth, comprehensive sleep study, probably the right place to go is to a accredited sleep center like this one.
That's exactly correct.
If I need a sleep study, what do I do?
Well, you should talk to your physician, and you should contact Olean General Sleep Lab. But really, going through the primary care doctor is probably the best
Great.
thing.
That's the one I didn't want to miss, and that's the closer for today. Thank you for being with us. If you'd like to know more, go to www.ogh.org Sleep Center. Thank you for being with us today. Have a great day.